Hi guys, good evening, good evening, good evening. I hope everybody is doing well, everybody is doing fine. I hope everybody is able to hear me. Can you all see me? Can you all hear me? A quick feedback on the chat box, please. ठीक है, चलो. So yesterday we spoke about the presentation of the inguinal hernia. Today we'll talk about the repairs in the inguinal hernia and then we'll move forward from there. ठीक है, चलो. So when you talk about the management, of the inguinal hernia. So I'll take up the topic as management. We'll talk about the management of the inguinal hernia. Now, when you talk about the management of the inguinal hernia, again, hernias must be surgically repaired. There's no other alternative forms that we have in the current scenario, right? Source of energy, namaskar sir, namaste beta, namaste. क्या बात है यार, आकाश शुभ संध्या. ये कुछ ज़्यादा हिंदी नहीं हो गया? थोड़ा इनफॉर्मल रखो यार, ठीक है? चलो. So when we talk about the management of the inguinal hernia, we'll be talking about various surgeries that we have, how do we repair it, what are the options that we have. We'll just look into it. But before we move down, there are certain terms that you should know. The first term is what we call it as herniotomy. The second term is what we call it as herniorrhaphy. And the last term is what we call it as hernioplasty. So I want you to understand that three terms that are going to be present. Number one is the herniotomy. Number two, it is going to be herniorrhaphy. Another one is going to be hernioplasty. Let's try to understand what do you mean by this, right? Now, if you take this as the representation of the patient, and for the sake of understanding, let's say this happens to be the anterior superior iliac spine. This is the pubic tubercle. This is the pubic symphysis, and this happens to be the pubic bone. This happens to be the pubic bone, right? Right, dead in the center, you have the midline. So this is the midline that is going to be present. This is somewhere across here, you have the umbilicus. And let's say this is the area that you have. Now, what is going to happen is, in order to repair, I'll talk about the open inguinal hernia repairs. Let's say this is where your inguinal ligament is present, right? And this is where you have the superficial inguinal ring, and this is the covering that you have. Posteriorly, you have the fascia transversalis. Now, what you're going to do is the first incision that you're going to put, the first incision is going to be skin. Now, once I open up the skin, right? Once you open the skin, what do you see? The next one, it is going to be subcutaneous fat. Under the subcutaneous fat, what do you have? Now, as soon as you open up the subcutaneous fat, you will now see the external oblique aponeurosis. So, when you open up the skin, if I just give you the objective, let's say this is the skin that you have opened up. Now, as you have opened up the skin, you will see the subcutaneous fat. So, the next layer that you have is the subcutaneous fat. The next layer that you have is the subcutaneous fat. So, this is now subcutaneous fat is open. The minute you open the subcutaneous fat, you have, this is your external oblique aponeurosis. This is your external oblique aponeurosis, and on the medial end, you see this is your superficial inguinal ring. This is how it is going to look like. Okay. So I have opened the skin, I have opened the subcutaneous fat, I have now exposed the external oblique aponeurosis. Now what I'm going to do is, I'm going to go and incise the external oblique aponeurosis. Now the minute I go and incise, if I incise the external oblique aponeurosis, I have opened up the external oblique aponeurosis. This is how the external oblique aponeurosis is going to be opened. So like a sheet, I have opened the external oblique aponeurosis. Now imagine that this is how the external oblique aponeurosis is being flipped out. So you have now flipped the external oblique aponeurosis. Okay? So this is the external oblique aponeurosis that you have opened up. On the either end, you have opened the external oblique aponeurosis. Now, if you open the external oblique aponeurosis, logically, what should you get? Now, if you have this is the external oblique aponeurosis. Inside the external oblique aponeurosis, you have your vas deferens, right? So you have noticed the minute you do this, you see there's a structure which is going to be passing through this. Let's say the deep ring that you have. So, okay, the minute you open the external oblique aponeurosis, the innermost layer that you're going to see is going to be your fascia transversalis. So let's say the innermost layer that you're going to see here, it is going to be the fascia transversalis. This is the fascia transversalis, and we all know the defect in the fascia transversalis. The defect in the fascia transversalis is a deep inguinal ring. In the deep inguinal ring, what do you have? In the deep inguinal ring, you have the vas deferens which is traveling across here. So this is the vas deferens, right? So the minute you open up the external oblique aponeurosis, सर थोड़ा aponeurosis explain कर देंगे बेटा कल explain किया था ना what is an external oblique aponeurosis? It is an extension of the external oblique muscle that goes into a thin layer and that merges onto the rectus abdominis muscle. ठीक है? Now those who have just joined, we are talking about the repairs in this. So this is the outermost layer that you have. This is the skin. You have opened up the skin. Once you open up the skin, the next layer that you get is the subcutaneous fat. So this is the subcutaneous fat. Now after you have the subcutaneous fat, after you have breached the subcutaneous fat, you have the external oblique aponeurosis. You open the external oblique aponeurosis. If you use the external, if you open the external oblique aponeurosis, which is here, if you're not able to see, I'll just show this is the external oblique aponeurosis and this is your vas deferens. Okay? Just for the sake of understanding, I'll just simply label them as well. So the outermost layer that you have is the skin, which is here. Then you have the subcutaneous fat. Then this is your external oblique aponeurosis. When you open the external oblique aponeurosis, this innermost opening, that is your deep inguinal ring. The one that you've opened here was your superficial inguinal ring. This is your vas deferens. This happens to be your vas deferens. Along with the vas deferens, you will have, let's say you have the ilioinguinal nerve. So let's say this happens to be your ilioinguinal nerve. This is your ilioinguinal nerve. This is your ilioinguinal nerve, right? Now, as soon as you open up, obviously the outermost layer, that is the skin, has opened, then the subcutaneous fat, you have opened the external oblique aponeurosis. Now you have opened, the minute you open the external oblique aponeurosis, you have opened the inguinal canal. The minute you open the inguinal canal, what do you have? You have two structures, one is vas deferens, another one is ilioinguinal nerve. Behind this is your fascia transversalis, which is the posterior layer of the inguinal canal. Until this, it is clear. Now, what are we going to do this? What is hernia is, when you look across here, the hernia is nothing but, if a sac is going to pop out, it is going to come from the deep inguinal ring. It is going to come from the deep inguinal ring. Let's say it is going to come from the deep inguinal ring. If the sac is going to come from the deep inguinal ring and then it is going to pouch out, this is how the whole objective is. So this is how the sac from the deep ring it is coming. No, indirect inguinal hernia, indirect inguinal hernia का concept क्या था? Yesterday we spoke. No, in the indirect inguinal hernia, the entry point. In the indirect inguinal hernia, the entry point is going to be the deep inguinal ring. The exit is going to be superficial inguinal ring. Now, the minute you do this, you have now exposed the entire inguinal canal. You have now exposed the sac. Now, what I'm going to do is I'm going to pull the sac up. Now, the minute I pull the sac up, what is going to be representation when I pull the sac up? Now, this was our fascia transversalis. I'm showing the posterior most segment. This is the fascia transversalis. The defect in the fascia transversalis was a deep inguinal ring. Now, from this you see that the sac is going to pop out, right? So what I'm going to do is this sac that is present, I'm just going to pull it up. Okay, so this is the sac that is coming from here. Okay. Now, from the same context here, you have the ilio-inguinal nerve which is going. Along with that, there is this vast difference which is going here. Okay. Now, what you do is, I am going to open up. I am going to open up the sac from here. When I open up the sac, this opening of the sac is what we call it as herniotomy. The opening of the sac is called as herniotomy, right? Now, once you open the sac, why you have opened is, I need to see what is inside the sac. Let's say inside the sac you have the bowel as the content, right? This was the bowel that is present in the content. Now, once you open the sac, the herniotomy is done. I will now exert pressure. I will now exert pressure. I will now exert pressure from this open segment and try to push the bowel back into the abdominal cavity, right? I'm trying to push the bowel back into the abdominal cavity, and slowly you will see this bowel is going to regress back. Now, as it regresses back, it reduces into the abdomen. As it regresses back, it reduces into the abdomen. And once it regresses to the abdomen, what are we left out with? Once it regresses into the abdomen, what are we left out with? We are going to be left out with an empty sac. So, the same representation we are going to continue here. This happens to be your fascia transversalis. This is the fascia transversalis. There's a defect in the fascia transversalis. There's a defect in the fascia transversalis. We know that there are two structures are going to roll from here. This is your vas deferens. This happens to be the ilio-inguinal nerve. And you now see the sac which we have opened. This is the sac which I have opened, and the content is reduced. Okay. Now the sac has become empty. What is this sac? The sac is nothing but made up of peritoneum. This is the sac, no? So what is the sac made up of? The sac is made up of peritoneum. The sac is made up of peritoneum. Until this point, you have done herniotomy. Now you have pushed the content back. Pushing the content back is what we call it as reducing the content. It is what we call it as, the term is called as reducing the content. Now, the word reducing the content basically means to push the content back into the abdominal cavity. It is to push the content back into abdominal cavity. Back into the abdominal cavity is what we call it as reducing the content. Now, once you have reduced, the sac is empty. Now, once the sac is empty, what are we going to do? We are going to plicate the sac. What do you know plicating the sac is? Now, what I'm going to do is, I'm going to take this sac and I'm going to rotate it. I'm going to rotate it. So, basically what we do is we attach any two instruments. Let's say I have attached an artery forceps here and I have attached another artery forceps here. Let's say this is an artery forceps here. There's an artery forceps here that we have attached. Now, once you're holding these two, and I'll just try to twist it. Now, as I continue to twist it, the whole sac is going to plicate, right? So, this is what we call it a sac plication. So, once the sac plication is done, what is the end result that you're going to get? The end result is going to be this is your fascia transversalis. This is going to be your fascia transversalis. This is the defect that we're talking about. This is the vas deferens. This happens to be the ilio-inguinal nerve. And this was the peritoneum that was coming out from here. Now, what we have done is we have plicated the peritoneum. So, once you plicate the peritoneum, the peritoneum would become like this, right? The peritoneum would have become like this, right? So, you have twisted the entire peritoneum. Now, as you have twisted it, this has now become like this. So, what I'm going to do is I'm going to take a ligature. I'll take a ligature and I will tie the ligature here, right? Once I've tied the ligature here, actually I'll double tie the ligature so that I'm sure it. Now, once I've tied the ligature, I am going to excise this redundant I'm going to excise this redundant sac. Excise the redundant sac. Now, once you excise the redundant sac, what are you left out with? The end result of this entire activity that we did. So, this is the same. So, this happens to be our fascia transversalis. We have excised that additional sac that we had. So, same thing here. You have the deep inguinal ring which is present here. This happens to be our vas deferens. This happens to be our ilioinguinal nerve. And this time the peritoneum that we have plicated is now regressed back. So, peritoneum that you have plicated, is now regressed back into the abdominal cavity. Sir, my first year student so may understand your concept. Beta, it's basic anatomy. If you're a first year student, thoda difficult hoga because you don't have the initial grip of the anatomy, but then more or less it's how it is gonna be. Okay? Now, once you have done this entire process, so kahan se shuru kiya tha humne? Now we started with opening of the inguinal canal. How did we open the inguinal canal? I did a opening of that, again incision onto the skin, then the subcutaneous fat, then you had the external oblique aponeurosis, you opened. The minute you open the external oblique aponeurosis, you are inside the inguinal canal. Inside the inguinal canal, you see vas deferens, ilioinguinal nerve, and then this is the sac that is going to pop out. Behind this, what do you have? You have the fascia transversalis. Now, once you have isolated the sac, I am going to open the sac, and this opening of the sac is called as herniotomy. Now, once you do the herniotomy, you reduce the content back, and then you start plicating the sac. Once the sac is plicated, this is how the end result is for sac plication. This is what we call it as sac plication. Just give me a second, guys. Okay. So this is what we call it as the sac plication. This is what we call as sac plication. And this is what we call it as excision. It is the excision of the redundant sac. Excision of the redundant sac, that is excessive sac, right? So the sac plication is to be done and the excision of the redundant sac, and this is what we basically call as the concept of herniotomy. Ho gaya, khatam. Now, if you do a tissue repair, that means if I take some tissue and I start repairing this posterior wall, if I start repairing this posterior wall, this tissue repair of the posterior wall. Now you have to make sure that you should always do the posterior wall repair, leaving behind the vas deferens and the ilioinguinal nerve. This posterior wall repair is what we call it as herniorrhaphy. If you do a posterior wall strengthening, with tissue, this is what we call it as herniorrhaphy. Now, if the same thing that you have done, if I put something else, let's say the same thing, if I do it with a Prolene mesh, if I do it with a mesh, this will call as hernioplasty. If the posterior wall strengthening, if the posterior wall strengthening is done with the mesh, if it is done with mesh, this is called as hernioplasty. So you now know what is a herniorrhaphy and you know what is a hernioplasty. Okay? So if the concepts are clear, first you open up the sac, you reduce the content, you plicate the sac, that is called as herniotomy. Once you're done with that, if you do a posterior wall repair only using tissue material or only taking sutures, it is called as herniorrhaphy. But if you put a mesh and trying to make it more stronger, it is what we call as hernioplasty. So three terms that we have here that you introduced. What is herniotomy? What is herniorrhaphy? What is hernioplasty? In herniotomy, it is to open the sac, reduce the content, and plicate the redundant sac. This is what we call as herniotomy. What is herniorrhaphy? Herniorrhaphy is your posterior wall repair using tissue and suture. Is herniorrhaphy. Hernioplasty is posterior wall repair or posterior wall strengthening using mesh. So this is the simplest explanation that you can find on the basis of herniotomy, herniorrhaphy, as well as hernioplasty. So herniotomy, herniorrhaphy, as well as hernioplasty, these are the recurrent, concepts that keep asking you for the same again. Okay? Now, let's talk about how are we going to repair it. So when you talk about the repairs, so when you talk about the hernia repair, I have two varieties of repair that I can offer you. One, it is going to be open repair. One will take an open repair, another one is going to be laparoscopic repair. One will do an open repair, another one will do a laparoscopic hernia repair. Another one that we are going to do is going to be a laparoscopic hernia repair. Now, when it comes down to open repair, what are the various methods of open repair that you have? So when you talk about the open repairs, the various methods of the open repair that you need to consider. Number one, if it is only suture repair, that's called as open suture repair. When you do an open suture repair, that means there is no mesh used, only it is going to be pure tissue repair. This is also called as the pure tissue repair. This open suture repair is also called as the pure tissue repair. Now the examples that it qualifies as, number one is the Bassani surgery. Number two is going to be Shouldes. Number two, it is going to be Shouldes. Number three is our great Mohandas Dasada. So it is an Indian called as the Dasadas repair. It is the Dasada surgery. Another example is going to be the Maloney Darn surgery. So you have the Bassanis, you have the Shouldes, you have the Dasada, and you have the Maloney Darn. These are the example. These are the example of your open pure tissue repairs. Okay? Then you have the mesh repair. So we have the open mesh repair. So when you talk about the open mesh repair, the best example that I have is Lichtenstein. It is Lichtenstein tension-free mesh repair. It is the Lichtenstein tension-free mesh repair is what we call as the open hernia repair with mesh placement. Nipur, hello, hi. Artistic thoughts, which year? बेटा आप मेरे से पूछ रहे हो कि which year और आप ये पूछ रहे हो कि which year's class. अगर आप ये पूछ रहे हो which year's class, then it is your final year class. ठीक है? If you're a third year, you're more than welcome to watch it, but final year is what is going to be concentrating on. ठीक है? So this is your open hernia repair. Now you have something called as the complex mesh repair. So you have the open complex mesh repair. You have the open complex mesh repair. Okay. Now, what are the examples of the open complex mesh repair? Number one is mesh plugs. Number two is going to be hernia systems. Now, both of them are not recommended now. Both of them are not recommended. Okay? So, you don't need to do this. Then you have the open preperitoneal repairs. Open preperitoneal repair. So don't worry about what is this preperitoneal repair. I will teach you in detail about where to place the mesh, how to place the mesh, all that will come into picture. For now, you remember it is going to be either a transinguinal approach or a Stopa's repair. A transinguinal approach. A transinguinal approach or a Stopa repair. Or a Stopa's repair. Okay. So this is all the open hernia repairs that are present. Now, what are the laparoscopic hernia repairs? When it comes down to laparoscopic hernia repair, in the laparoscopic hernia repair, I can divide them into two common categories that we have. Number one is what we call it as TAPP. Another one is what we call it as TEP. So TAP and TEP are the two common words that you have. Notice TAP stands for. TAP stands for transabdominal. TAP stands for transabdominal preperitoneal repair. It is a transabdominal preperitoneal repair is what we call it as TAP. What is TEP stands for? TEP stands for total extraperitoneal repair. It is the total extraperitoneal repair. It is a total extraperitoneal repair. Absolutely correct. Now, we'll be talking about each one of them. We'll talk about how do you place meshes and all that. But before we move down, I want to understand the laparoscopic inguinal hernias anatomy. Okay? So I'm going to talk about the laparoscopic inguinal hernias anatomy. So this is going to be quite interesting. So we'll talk about the laparoscopic inguinal hernia anatomy. Now, what do you mean by the laparoscopic inguinal hernias anatomy? So let's try to understand. Now you have to see, until now we have seen the anatomy from outside to inside. Now you have to see inside to outside. Now imagine you are inside the room, you are inside the abdominal cavity. What is it going to look like, right? Now when you go inside the abdominal cavity, now the outermost that you have is going to be the skin, no doubt about it. Under the skin, what do you have? You have the subcutaneous fat, that is your campers and scarpa. So we're just going to keep it as subcutaneous fat. Okay. Now I'm just going to skip all the rest of them. So you have two more layers that you have to put across here. One, it is going to be, this is your fascia transversalis. Then you have under the fascia transversalis, this is the peritoneum. This is the peritoneum that is present. Now if you just draw the midline, just for the sake of understanding, this is the midline that is present. Okay. Just for the sake of understanding, this happens to be the skin. This is the subcutaneous fat. This happens to be the fascia transversalis. And this happens to be peritoneum. So you have the skin, the subcutaneous fat, the fascia transversalis, and the peritoneum, right? So these are the structures which are present. Now, when you look deeper into this, now we have two things that you need to understand, right? One, there has to be superficial inguinal ring. Second, there has to be a deep inguinal ring. Just for the sake of understanding, I am going to create a, this is the, let's say, external oblique aponeurosis with the transverse abdominis muscle. So this is an aponeurotic tissue which is present here, right? On the lateral side, I can simply say it is an external oblique aponeurosis. So I can say this happens to be the external oblique aponeurosis. Okay. Now, you need to understand that each of them is going to have their openings which are going to be present. One opening will be here, that is your superficial inguinal ring. Another opening will be here, that is going to be a deep inguinal ring. So this is your deep inguinal ring which is present on the either side. Okay. So these are deep inguinal rings. So you have two components, the superficial inguinal ring and the deep inguinal ring. You will notice that the vast difference which is going to enter. It will enter from the superficial inguinal ring, goes into the deep inguinal ring, and I told you that it is going to turn medially. The same thing is going to happen here. It is going to go from the superficial inguinal ring, goes to deep inguinal ring, and it is going to turn medially. So this is the normal orientation that you have. So when you're standing inside, so imagine you are here. Imagine that you are standing right across here. Imagine that you are standing right across here and you are looking up, right? You are looking up. Now, when you look up, what is the first layer you find? You see there is a peritoneum there. Then you see there is a deep inguinal ring. So this happens to be the deep inguinal ring which is here. This happens to be vas deferens. This is your superficial inguinal ring. So superficial inguinal ring, vas deferens, and the deep inguinal ring is present in this particular context. Okay. Now, whenever you want to do a hernia or a repair, you need to understand what is the hernia per se. Let's say if you talk about indirect inguinal hernia, you see the peritoneum going from the deep ring, coming here in the superficial inguinal ring, and it is going to pop out here. If I just make this, what I'm trying to tell you, this is how the hernia from inside would look like, right? You would see the peritoneum enter into the deep inguinal ring. It goes along the deep inguinal ring. It travels the whole context, comes out of the superficial inguinal ring, and this is how the sac is going to be formed. So this is your peritoneum which is moved from here, exited from the superficial inguinal ring, and this is how the sac is going to pop out. Obviously, this sac is going to be covered by the subcutaneous fat. This will also be covered by the skin that is just next to it, right? So this swelling that is popped out, is nothing but your indirect inguinal hernia that is coming from, it is coming directly from the deep inguinal ring, going here and then coming from the superficial inguinal ring. If it comes directly from the posterior wall and then it pops out, this is what your direct inguinal hernia is, as simple as that. Now my goal is to pull this peritoneum down. So all the content is reduced. I'm going to take this peritoneum, I'm going to pull it down. Now as I pull the peritoneum down, you see the entire peritoneum is going to come down and then the whole side is going to come off. Okay? Now once you do this, I'm going to dissect this to achieve the same component. Okay? Now you understood the whole concept. Now I'm trying to bring it down. We'll bring the roof down. Okay? So this was the skin that we just spoke about. Under the skin, you had the subcutaneous fat. So this is the subcutaneous fat, right, that we have. Under the subcutaneous fat, let's say this happens to be the fascia that is going to be present. This is the fascia. This is the superficial inguinal ring on the either side, which is going to be here, right? Then you have your fascia transversalis with the deep inguinal ring. This is the fascia transversalis with the deep inguinal ring. This happens to be the peritoneum, which was here. We have just brought it down. We have pulled the peritoneum down now, right? Everything else is the same. Your vas deferens is going to move from here. It is moving. The vas deferens here is also going to go inside this and then going to move medially. The midline, for the sake of understanding, will still remain at its mid position, which is going to be here. Now I've reduced, now I've pulled, I see the whole peritoneum is down. Now all that you have to do is you have to bring this peritoneum even further down. Now if you pull this peritoneum even further down, I've opened up the peritoneum. Now as I open the peritoneum, this is how you would look like. So this is the peritoneum which is going to be continuous, which is here. Now once you pull the peritoneum down, what do you have? Now you see the vas deferens is clearly exposed. You will now see that the vas deferens is going to be clearly exposed. Right next to the vas deferens, you have the testicular vessels, also called as the gonadal vessels, that is gonadal artery and the gonadal vein. And in between this, you have the external iliac artery, which is going to be present along with the external iliac artery, there is an external iliac vein also present. So there is an external iliac artery and there is this external iliac vein. Okay. So you see there is this triangular area. ठीक है बेटा इंग्वाइनल कैनाल के बारे में पढ़ना है यू हैव टू गो बैक टू आवर फर्स्ट वीडियो लेक्चर ऑफ द हर्निया दैट इज ऑन मंडे तो मंडे के दिन मैंने आपको बड़े प्यार से पूरा कॉन्टेक्स्ट ऑफ इंग्वाइनल हर्निया पढ़ाया था तो इंग्वाइनल कैनाल की एनाटॉमी वहीं पे है जस्ट गो वॉच इट ठीक नाउ एज आई पुल द पेरिटोनियम डाउन see this if I just label it down this happens to be the peritoneal surface so this is the inferior surface the inferior surface is made up of peritoneum. It is made up of peritoneum. Then you have medial structure. Medially, you have your vas deferens. Then this is your lateral structure. The lateral structure is made up of your gonadal vessel. It is made up of your gonadal vessel. This is your external iliac artery. This is your external iliac vein. And then the apex is formed by your deep inguinal ring. So I can say the apex of this whole context is your deep inguinal ring. So between the deep inguinal ring, the vas deferens, the gonadal vessels and the peritoneum, you see this area which is present here. You see this area which is present here. This area which I have shaded. This area which is present here is what we call it as the triangle of doom. This is what we call it as the triangle of doom. So the whole concept that I just explained you, this whole concept is about triangle of doom. We call it as triangle of doom because injury to this area will result in catastrophic effort. Injury to this area will cause a catastrophic effort. So triangle of doom is the whole concept that you have. So this triangle that you can see is the triangle of doom. So triangle of doom medially, if I just quickly do a recap for you. Medially it is formed by vas deferens, laterally it is formed by gonadal vessels, inferiorly it is formed by peritoneum and the apex is formed by the deep inguinal ring. But if I say what is the content? The content is going to be external iliac artery and the external iliac vein. Injury to this area will cause doom, hence it is called as the triangle of doom. This is called as triangle of doom. Now what is this triangle of pain? Right next to it, no, ye jo area that is the triangle of pain. So this area which you can see between the gonadal vessel, between the gonadal vessel, peritoneum and the iliopubic tract, this is what we call it as the triangle of pain. This is what we call it as the triangle of pain. This area which I have just shaded in pink, this is what we call it as the triangle of pain. This is what we call it as the triangle of pain. Now when you say triangle of pain, the triangle of pain is formed by your gonadal vessel which is here. This is the gonadal vessel. So gonadal vessel here is going to become the medial boundary. So this is going to be the medial boundary. This will be the lateral boundary. This will be the inferior boundary. The apex is still the deep inguinal ring. Correct? Now, when I just label it, inferior boundary, it is formed by the peritoneum. The medial boundary, it is formed by the gonadal vessel. The lateral boundary is formed by the iliopubic tract. It is formed by the iliopubic tract. And the apex is formed by your deep inguinal ring. It is formed by deep inguinal ring. And here when you notice, you got multiple nerves which are going to be formed. So there are multiple nerves which are going to be present. In fact, one of the most common nerves that are going to get injured here, it is going to be your lateral cutaneous nerve of thigh. So femoral, lateral cutaneous nerve of thigh, femoral branch. Okay, fine. Yeah, there are 5 nerves. I'll list them when we talk about the repairs. Don't worry about it. So sorry to disturb in the middle of the class. In the Shushruth Bath surgery ka trauma second video kab aayega? Beta already trauma. Acha, those who are looking for the trauma videos, especially in the Shushruth batch, no. Guys, I've done the entire trauma series on a BLS. So अगर आप BLS खोलोगे उसमें ट्रॉमा लेक्चर पूरा है, स्टार्टिंग फ्रॉम योर प्राइमरी असेसमेंट ऑल द वे टू योर सेकेंडरी असेसमेंट. वी हैव डन एवरीथिंग स्टार्टिंग फ्रॉम द ट्राज with the organ specific injuries also. ठीक है, all that you have to do is to go back, just look at the BLS series of the trauma, and in trauma you have all the lectures. ठीक है, Shushruत batch अलग से we are planning up, that is for the final year, that is going to be exclusive in that context. ठीक है, so don't worry about it. So यहाँ पे दो triangle हो गए, triangle of doom और triangle of pain. अगर आप दोनों triangle को मिला, if you combine these two triangles, that is if you combine the triangle of doom with the triangle of pain, if you combine the triangle of doom with the triangle of pain, this is what we call it as the trapezoid of disaster. This is what we call it as the trapezoid of disaster. Okay? Now, it is called as the trapezoid of disaster because if anything goes wrong in this area, it is going to cause a lot of problem. In fact, this is also called as the electrical hazard zone. This is also referred to as the electrical hazard zone. Also referred to as the electrical hazard zone. That means the cautery should not be used in this area. If you use cautery in this area, there is a higher chance of causing injury to the vessel as well as nerves, so better to avoid it. Now, just to complete the whole discussion, there is another small context here which is called as the corona mortis. So let's understand what is corona. We have corona mortis. Now, this corona mortis is also called as the crown of death. This is what we call as the crown of death. Now, what does this crown of death basically means? Now, if you take this as a representation of the anterior superior iliac spine, this is the pubic rami, this is the pubic tubercle, this is the pubic symphysis. Now, if you connect all these together, this becomes your pubic bone. This becomes the pubic bone. And let's say this is the midline that is present, right? Now, you have the aorta which is present here. It has the common iliac bifurcation. Then it goes into external iliac and the internal iliac. So let's say this is the external iliac vessel and this happens to be the internal iliac vessel, right? Now, from the external iliac and the internal iliac, there is one blood vessel which is going to come. From the external iliac, there are going to be your inferior epigastric artery. And from here, this is going to be an obturator artery. So, you see there is an inferior epigastric artery which is going to arise from here. This is the inferior epigastric artery which is going to arise from here. This is the inferior epigastric artery arising from the external iliac artery, and this happens to be your obturator artery which is going to be rising from here. This is the obturator artery. So, there are two blood vessels. One is going to be your inferior epigastric artery, another one is your obturator artery. So, normally this is what is going to be present. In few patients, you will find an abnormal communication between these two behind the pubic rami. So, if you take this as a representation, this is the pubic rami. Just for the sake of understanding, you cannot see behind the pubic rami, it is on the posterior side. ठीक है, तो ये pubic rami है. So, this is the pubic rami. You cannot see what is on the posterior aspect of the pubic rami. So, this is the pubic rami and the pubic bone. Okay. Now, our objective is where is this corona mortis coming from? Now, the corona mortis is actually an abnormal communication between the inferior epigastric artery and the obturator artery, also called as the aberrant obturator artery. It is also called as the aberrant obturator artery. Now, this aberrant obturator artery is actually an abnormal communication. So, if you take this as the representation of your inferior epigastric artery, you see there is an abnormal communication between the inferior epigastric artery, and the obturator artery. So, this is going to be going across here. So, there is an abnormal communication there is an abnormal communication between the inferior epigastric artery and the optic artery behind the pubic bone. So if you say this is the pubic bone, it is going here. दिख रहा है नहीं दिख रहा, it is like this, पीछे की तरफ है, ठीक है. Now why it is important is when you're putting the mesh in the laparoscopic inguinal hernia, the mesh goes from inside. Now you want the mesh to be anchored, you want the mesh to be fixed. So we use the screw small button like which is called as tackers, and we're going to put it to the bone. Now if you don't know that this anatomy exists and you try to tack, usually the tacker is applied at the pubic tubercle and this vessel also goes through that area only, and if you just punch it, you're going to cause injury to this blood vessel. Problem is not that. The minute it injures, no, it is going to retract back. Arteries, they're high elastic. So when they recoil, they start bleeding. Now bleeding is not going to flow from one blood vessel. It will bleed from the inferior epigastric artery. It will bleed from the optic artery. When they both bleed, they are the branches of external internal iliac artery, which itself is a branch of common iliac artery, which itself is a branch of aorta, and that bleed is going to be absolutely torrential. And that absolutely torrential bleed will result in significant hemorrhage and death. So hence the name is called as corona mortis. Sir, I'm not able to orient those triangles in the real body. If possible, please help. It is absolutely possible. We will help you. Don't worry about it. So for now, I hope you understood the corona mortis. The corona mortis, it is defined as an abnormal. It is an abnormal communication. It is an abnormal communication between inferior epigastric artery and the obturator artery on the posterior surface of pubic rami, near to pubic tubercle. This is what we call it as the corona mortis. This is what is corona mortis. ठीक है? शहजाब क्या बोल रहे हो सर? प्लीज टेल अस इन हिंदी. ठीक है बेटा, पूछो यार क्या सवाल. आप शाबाश बेझिझक सवाल पूछो, क्या पूछना पूछो, आपको आराम से हिंदी में बताएंगे, कोई टेंशन नहीं. ठीक है. सो दिस इज विद रिस्पेक्ट टू कोरोना मोर्टिस. नाउ समबडी सेइंग कि सर ये जो ट्रायंगल्स है ना बॉडी में समझ में नहीं आ रहा. ठीक है. नाउ इमेजिन करो, ज्यादा डिफिकल्ट नहीं, इमेजिन करो कि ये जो रूम में मैं खड़ा हूं, ये मैं रूम में जो खड़ा हूं, इट इज योर एब्डोमिनल कैविटी. ठीक है. जस्ट फॉर द सेक ऑफ अंडरस्टैंडिंग, जिसको नहीं समझ में आया उसको समझाने के लिए इमेजिन करिए कि पेशेंट लेटा हुआ है. ठीक है. द पेशेंट इज लाइंग डाउन सुपाइन. एंड ये पेशेंट का थोरैक्स और एब्डोमेन. ठीक है. जस्ट फॉर द सेक ऑफ अंडरस्टैंडिंग इसको मान लो कि ये अम्बलाइकस है. नाउ दिस इज यू. आई पोजीशन यू इनसाइड द एब्डोमेन ऑफ द पेशेंट. आप पेशेंट के एब्डोमेन के अंदर हो एंड यू आर लुकिंग अप. ठीक है. आप पेशेंट के एब्डोमेन के अंदर चले गए हो और आप ऊपर देख रहे हो. ठीक है. आप ऊपर देख रहे हो तो क्या दिखा? ऊपर देखना है और टुवर्ड्स द पेल्विस देखना है. ठीक है. तो आपकी नजर अच्छी नहीं है, सो यू आर एक्चुअली लुकिंग हियर. ठीक है. ये आपका लुकआउट है, तो आप अंदर आ गए एब्डोमेन के एंड यू आर लुकिंग टुवर्ड्स द पेल्विस. तो मैं ये देख रहा हूं. ठीक है. ये पेल्विस की तरफ देख रहा हूं. अब जब मैं पेल्विस की तरफ देख रहा हूं, मुझे दिख क्या रहा है? ठीक है. लेट्स टेक द सेम कॉन्सेप्ट हियर एंड वी ट्राई टू बिल्ड अप. नाउ जब आप देखोगे आउटर मोस्ट, अगर मैं देखूंगा, इफ आई जस्ट स्प्लिट इनटू लेयर्स, आउटर मोस्ट इज गोइंग टू बी द स्किन. स्किन के नीचे क्या आता है? आपका सबक्यूटेनियस फैट आता है. सबक्यूटेनियस फैट के अंदर, इफ यू टॉक अबाउट द लैटरल साइड, यू हैव द लैटरल एब्डोमिनल वॉल मसल्स. तो लैटरल एब्डोमिनल वॉल मसल में बोल सकता हूं कि एक्सटर्नल ओब्लिक मसल आ जाएगा, इंटरनल ओब्लिक मसल आ जाएगा. ठीक है. ट्रांसवर्स एब्डोमिनस आ गया. उसके अंदर क्या आ गया? आपका फेशिया ट्रांसवर्सालिस आ गया. फेशिया ट्रांसवर्सालिस के अंदर क्या हो गया? इसके अंदर आपका पेरिटोनियम हो गया. और आप कहाँ पे हो? यू आर स्टैंडिंग हियर. सेम एनालॉजी, यू आर स्टैंडिंग हियर एंड दिस इज योर लाइन ऑफ विजन. तो ये आप ऐसे देख रहे हो. ठीक है. तो आपको एब्डोमेन के अंदर ये दिख रहा है. नाउ क्योंकि आप इंग्वाइनल रीजन में देख रहे हो, इंग्वाइनल रीजन में आप देखोगे कि फेशिया ट्रांसवर्सालिस में ना एक छोटू सा डिफेक्ट मिलेगा और इस डिफेक्ट को आप बोलोगे ये आपका डीप इंग्वाइनल रिंग है. ठीक है. फिर आप देखोगे ऑन दी external oblique aponeurosis, तो if you take this area, just for the sake of understanding, इसको aponeurotic tissue कर देता है, ठीक है. Now imagine that this area is external oblique aponeurosis, and at one point this is going to be only the external oblique aponeurosis और कुछ बचता नहीं यहाँ पे. That's on the medial end, ठीक है. This external oblique aponeurosis also has an opening, and that opening is what we call it as the superficial inguinal ring. तो इन दोनों के बीच का अगर आप पैसेज देखोगे, ये आपका superficial inguinal ring होगा, ठीक है. So this is your superficial inguinal ring. Now, if you look at the passage, between these two, ये आपका vas deferens है, which is going to run in the inguinal canal, goes into your deep inguinal ring and is turning like this, ठीक है. यही हो रहा है आपका. क्लियर. तो आप देख रहे हो अंदर, मेरे को जब देख रहे हो ना, क्या दिख क्या रहा है आपको? आप देख रहे हो कि अंदर जो सबसे अंदर है वो पेरिटोनियम है, ठीक है. आपने पेरिटोनियम देख लिया. इसके जस्ट पीछे आपका फेशिया ट्रांसवर्सालिस जो अभी दिखेगा नहीं, इसके पीछे आपके मसल्स हैं, इसके पीछे आपके मसल्स हैं, और देन यू हैव दी सबक्यूटेनियस फैट, और इसके पीछे आपका स्किन है. तो ऑब्वियसली जब आप अंदर खड़े हो, ठीक है, जब आप ऐसे देख रहे हो, मुझे तो सिर्फ पेरिटोनियम नजर आएगा ना. आगे क्या है? सिर्फ पेरिटोनियम है. आई कैन ओनली सी पेरिटोनियम, मुझे और कुछ दिख नहीं रहा, क्योंकि वास्ट डिफरेंस पेरिटोनियम के अंदर है. तो मैं क्या करूंगा, एक काम करते हैं, पेरिटोनियम खोल देते हैं. तो आई हैव डिसाइडेड टू ओपन अप द पेरिटोनियम. तो मैंने यहाँ पे पेरिटोनियम पे एक चीरा मारा और पेरिटोनियम को खोल दिया. नाउ व्हाट आई हैव डन इज आई हैव ओपन अप द पेरिटोनियम लाइक दिस, ठीक है. अब जैसे ही पेरिटोनियम खुलेगा, द मिनट द पेरिटोनियम इज गोइंग टू गेट ओपनड, दिस इज हाउ इट इज गोइंग टू बी. Now, the minute I open up the peritoneum, I am now allowing the vas deferens. I am now allowing the vas deferens. I am now allowing the vas deferens to appear like this. ठीक है. अब ये जो है, ये अभी भी वॉल के साथ ही चिपका है. हमने बस पेरिटोनियम निकाला है यहाँ पे. It is still with the wall only. ठीक है. It is adherent to the wall. To make it more easy for you to understand, ये अभी भी वॉल के साथ ही चिपका हुआ है, ठीक है. तो ये आपका वास डिफरेंस अभी वॉल के साथ चिपका है. फिर आप देखोगे इसी वॉल के साथ चिपकू एक और ब्लड वेसल है, ये आपकी गोनोडल वेसल है. तो मैं बोल रहा हूँ एक लैटरल होगी, एक मीडियल होगी, क्योंकि पेरिटोनियम खींच रहा है, आपको दिख रहा है, ठीक है. अब ये जो एरिया है, अभी आपने पेरिटोनियम नीचे खींचा ना, तो पेरिटोनियम इज हियर, ठीक है. तो आप देख रहे हो पेरिटोनियम को हमने खोल दिया. सो दिस इज हाउ वी हैव ओपनड अप द पेरिटोनियम, ठीक है. नाउ वंस आई ओपन अप द पेरिटोनियम, मैं पेरिटोनियम के अंदर देख पा रहा हूं. जब मैं अंदर देख रहा हूं, एक साइड में वास डिफरेंस दिख रहा है, एक साइड पे आपको गोनोडल वेसल दिख रहा है, और नीचे पेरिटोनियम पड़ा हुआ है, ठीक है. सो आई हैव ओपनड द पेरिटोनियम इज डाउन, मीडियल इज वास डिफरेंस, लैटरल इज गोनोडल वेसल, और ये जो ट्रायंगुलेटेड एरिया है, इसको आप ट्रायंगल ऑफ डूम बोलते हैं, लेकिन वो चिपका ऊपर ही है. It's up there only, ठीक है. So don't worry about it. I have a real time images also. I think operating videos we can show. It's not a problem, ठीक है. So this is how your triangle of doom and the triangle of pain would look like. Clear है? So far any questions? कोई सवाल, कोई शक? Clear? All right. So that's it for today's lecture. ठीक है. So next week when we come back, we'll talk about all the repairs. We'll talk about all the other components that we have in the hernia. We'll show you about the hernia videos. If possible, I don't know if the YouTube will allow us to do a clinical examination. If that happens, I would love to do that so as well. ठीक है. Thank you, Mohammed Basam. Thank you so much. ठीक है. If you have any questions, any queries, you know where to find us. You know where to write to us also. You can always write or send your queries to our Instagram page, that is the surgery guy. And the surgery guy is by my name, and my name is Dr. Sandeep Seeram Reddy. ठीक है. So it's by my name, that is Dr. Sandeep Seeram Reddy. नाम तो सुना होगा. ठीक है. Any questions, any queries? पूछना था. Thank you so much. We'll see you and see you. Bye. Thank you. Thank you, Mansoor. Thank you so much. Thank you, Mohammed Basam. Thank you so much. See, the whole idea is to, think I have only one goal, and the goal is to make you guys fall in love with surgery, nothing else. If that is achievable, then we have done our job well. Until then, see you next week. Bye. Thank you. Goodbye.